Hello everyone, my name is Taylor Servais and I'm the PGY2 Emergency Medicine Pharmacy Resident at UNC Health Southeastern. Today I will be evaluating the management of alcohol-associated vitamin and electrolyte deficiencies in the emergency department. I, nor any of my co-investigators, have anything to disclose related to this topic. First, we will discuss some background information. Patients with alcohol use disorder commonly present with multiple vitamin and nutrient deficiencies, and these patients are empirically prescribed banana bags. Banana bags usually contain a mixture of IV fluids, thiamine, folic acid, and multivitamins. And of these components, thiamine is arguably the most beneficial component for replacement for the prevention of Wernicke's encephalopathy. Recent literature suggests that not all alcohol use disorder patients warrant IV therapy with banana bags, and instead, components can be dosed individually based on the patient's symptom severity determined by their CWAS score. Furthermore, individual administration of each component may be associated with a faster time to administration of thiamine. Currently, at UNC Health Southeastern, patients presenting with alcohol use disorder are prescribed standard banana bags for replacement regardless of their symptom severity. This may lead to unnecessary IV administration of components and a potential delay in appropriate replacement therapy. The purpose of this study is to evaluate the management of alcohol-associated vitamin and electrolyte deficiencies in the emergency department. The primary objective of this study was to evaluate the time to thiamine administration, and the secondary objective was to evaluate cost savings associated with individual administration of these components compared to banana bag administration. The study center is UNC Health Southeastern, which is a community hospital located in Lumberton, North Carolina, that has 292 inpatient beds. The hospital admits roughly 20,000 patients per year and has over 70,000 patients visit annually. This study consisted of two phases. Phase 1 was a retrospective observational chart review, and Phase 2 was also a retrospective chart review following emergency medicine physician education. The study population included adult patients admitted through the emergency department with an order for thiamine as part of their alcohol-associated deficiency replacement. Phase 1 was completed May 1st through July 31st of 2020. Provider education was completed in December 2020, with Phase 2 beginning January 1st through March 31st, 2021. This is the table included in the physician education with the suggested thiamine dosing used during Phase 2 of the study. As you can see, recommended thiamine dose and administration is based on the patient's CWAS score. During Phase 1, 69 patients were screened for eligibility and were analyzed during the study. During Phase 2, 57 patients were screened for eligibility and were analyzed during the study. No patients were excluded in either phase. Descriptive statistics were used to summarize data. Continuous data was analyzed using students' t-tests, and a p-value of less than 0.05 is considered significant. Most baseline characteristics were similar between the groups. However, during Phase 1, we included more male patients and saw significantly less patients admitted to the hospital following ED management. For the primary outcome, there was a significant decrease in the time to thiamine administration when replacement was done via administration of individual components versus banana bags. However, there were a lot of outliers in this data set. Additionally, we analyzed the data excluding all administrations that were given more than 2 hours following the medication order. This exclusion decision was based on a UNC Health Southeastern policy that states the timing of all non-stat medication administrations are expected to be within 2 hours before or after the scheduled dosing time. After excluding all outliers, there was still a significant decrease in the time to thiamine administration when replacement was done via administration of individual components versus banana bags. For the secondary outcome, there was a medication cost savings of $1,704. Potential limitations to this study included the small patient population, which may limit external validity, the inability to include the cost of stay in the cost analysis, and the failure to educate the internal medicine and family medicine residents who rounded in the ED during our Phase 2 protocol. Discussion points that can be made from the analyzed data are that in alcohol use disorder patients, vitamin and electrolyte replacement via administration of individual components led to a significant decrease in the time to thymine administration compared to replacement with banana bags. Additionally, replacement with individual components was also associated with a reduction in medication costs. In conclusion, replacement with individual components significantly decreased the time to thymine administration compared to banana bag replacement. At this time, I would like to acknowledge my colleagues for their contribution to this project. And I would like to conclude with a self-assessment question. In patients with alcohol use disorder, how can we determine the appropriate route and dose of thymine for replacement? And the answer is based on symptom severity determined by the patient's CWAS score. Here, I have attached my references. Thank you for your attention, and I would be happy to answer any questions that you may have.